This is DGMT's Learning Lunch, and I'm your host, Rahima Esop. A 2025 study of obstetric violence conducted in KwaZulu-Natal and Gauteng found that 60% of women surveyed had experienced at least one form of harm during labor or birth. Now, this study is important data and evidence in South Africa's understanding of the prevalence of obstetric violence, so that advocates can push for legal and health system reform. So what's the situation currently? Our national laws and policies don't explicitly define or prohibit obstetric violence, and redress mechanisms are limited to reporting to professional bodies, the Ombudsman, various institutions that protect people's rights, or suing for malpractice. But for the black and working class women, migrants and adolescents who are disproportionately affected by obstetric violence, justice remains slow. It's limited and it's inaccessible. Resource barriers, legal complexity, and limited awareness are standing in their way. This is the backdrop for today's conversation about accountability in maternity services to ensure empathy, respect, and dignity for pregnant women and postpartum mothers. To talk about this, I'm joined by Julie Mentor, the project lead of Embrace, an organization advocating for respectful maternity care as well as legal and policy reform in the health sector for the benefit of all mothers. Welcome, Julie.
Thanks so much for having me on.
Julie, when survivors talk about violence and harm in maternity wards, they are talking about a range of harms, from physical abuse to subtle violations. What are the different forms of obstetric violence?
Let me just start with a broad definition, which is that obstetric violence is the disrespect, neglect, or abuse experienced by someone seeking healthcare, reproductive healthcare during pregnancy, birth, or postpartum at a health facility or via a health practitioner. And it can look like a number of things. So it can look like physical abuse, which could be pinching you in labor, slapping of your inner thighs, pushing hard on your abdomen in a way that hurts you. It could look like procedures given to you without your consent. We hear frequently of women who have episiotomies, which is a cut in the vagina to make more space for the baby, but is often done with limited or no pain relief and is a very invasive procedure that takes a long time to heal from. It could look like other procedures done without consent, such as cervical checks, which again are quite invasive, and every person should have the right to consent to that kind of procedure at every time. It could look like verbal abuse. Lots of women report being shamed, making maybe they're crying out in labor because labor can be very painful, and they're told things like they're sworn at. Told you weren't making this noise when you made the baby, so why are you making this noise now? Shamed because of their economic status or their sexual orientation or their nationality or their age. You know, you're 15. What business do you have of being here? It can look like being procedures like a cesarean section that you don't know that you consented to, or being forcibly sterilized against your will, either because of a reason like an HIV status, which is how forced sterilizations used to happen, and there are claims that they've happened quite recently, or because it happened in a medical emergency, but it wasn't explained or there was no post-counseling after the event. It happened and you didn't know why. It can look like a number of these things: denial of pain relief. It can look like not being listened to, not ignored, not having your basic needs met, having to give birth on a floor, not having a curtain for privacy, not having a clean sheet to give birth on, being alone, giving birth alone. It is something that deeply affects the people it affects, and it is a gross violation of their human rights.
And it's important to note that all of this is occurring in labor wards, which are high-stress environments where life-threatening obstetric emergencies demand intervention, yet the rights and dignity of women in labor are frequently disregarded. Julie, when did Embrace become involved in advocacy around obstetric violence, and how has your understanding of the prevalence of the problem evolved since then?
It's difficult to think of an actual start date of when this issue first came on our radar because our work is deeply rooted in mothers' lived experiences. And when you speak to women about motherhood, birth stories inevitably come up. About 6-7 years ago now, maybe slightly longer, we started a series of birth circles with women. And I remember sitting in some of those circles and just being struck by how many women were talking about what was really quite negative birth experiences, quite traumatic birth experiences. In some instances, women were very tearful. In other instances, women were talking about things that clearly sounded quite abnormal to me, but they were talking about them with a sense of like resignation, yeah, I was overcrowded, I had to wait hours for a bed, but that's kind of what happens. And so we started wondering, what's the state of birth like in South Africa, and just understanding how these women articulated about how their experience of childbirth went on to impact them. I remember hearing a story of a woman who gave birth 30 years ago who was crying, talking about how she was treated so brutally. You realize that the impact goes way beyond a day of birth. And I think that is something that is so important to understand about this issue, is that childbirth may feel long for the mother, but in context, it's a 2-hour to a 24-hour, maybe slightly longer experience.
If you're lucky, 2 hours. But what I want to ask is, back then, during those birth circle conversations 6 or 7 years ago, were people in South Africa using the language of obstetric violence?
I wouldn't say that it was nearly as popular as it is today. I think it's definitely growing its understanding, definitely amongst mothers. There were some incredible researchers that we are lucky to still be connected with today who were definitely writing about this issue. But no, I don't think obstetric violence was fully understood. However, we got the sense that what was happening was not only hugely traumatic for the women in that moment, but had lifelong, in some instances, impact on that woman, on her experience of family life, of her mothering journey, her ability to be productive in her community. So it had widespread effect, but limited understanding about what was actually going on. And what was really interesting was that women were also internalizing some of the fault. I must have not listened properly to what the doctor said, or I didn't come in time. And that just felt incredibly sad, because childbirth is such a transformative experience in your life. It's literally the transition into a motherhood journey, whether it's your first or your 10th time doing it. It's transformative every time. And when you're treated with compassion and care, that stays with you. You remember it. You can remember that kind nurse who helped you, or that caring midwife. When you're treated with disrespect, or when you're neglected, that also really stays with you. And so it felt like this was something we needed to understand. And so that sort of started a journey for us. Then in 2019, so just before COVID, we hosted a birth lekgotla, where we engaged with some of the researchers that we had found online who were engaging in some of this work. Rochelle Chadwick being one who just comes to mind, who's been writing about obstetric violence in South Africa for years. But others, civil society members, organizations who had an interest in working with women, either on sort of gender justice, through a gender justice lens, or interested in sexual and reproductive health rights. And we started unpacking, what is going on. And it became very clear that not just in our corner where we were operating, but much broader, women were experiencing obstetric violence. We just didn't know enough about it, or what we could do to kind of advocate for it. But there was a really keen interest to do so. And so then our sort of advocacy journey sort of had a life of its own. We were invited to participate in the second presidential summit on gender-based violence and femicide. And the idea was that internationally, obstetric violence was gaining some traction, specifically in Latin America, where it was being framed as a issue of gender-based violence. And that framing really made sense for us, because this is an issue that is both a human rights violation, but it's along gendered lines. And so we were able to convene a pregnancy and birth caucus on obstetric violence, again with activists, researchers, people who had come to attend that conference from around the country. And what was really powerful there was that in the resolutions that came out of the conference was a need to recognize obstetric violence as a form of gender-based violence, which felt like another little bit of a stepping stone win. But of course, while there was some incredible qualitative data coming out, there wasn't a real sense of quantitative data. And as we were starting to talk about obstetric violence and why this was a problem, just based on what we were really hearing on the ground, the sort of pushback was, oh, okay, yes, we've seen that story, because every now and then in the media, a terrible story will happen where something egregious has happened. A woman has been sterilized without her consent. A woman has lost her baby, or she herself has died. And that story will happen, and people will push back and say, there is a problem here. Mothers will say there's a problem. And the response back would be, yes, at this hospital, they've dropped the ball. Or, yes, we believe that healthcare practitioner, is not to be trusted. Or there might be a problem there. But not a sense that it was anything bigger. It was like, once off kind of issues. And so what we realized was there was a real need for prevalence data, and we didn't yet have that. So we realized what we really needed was a sense of numbers. This is not about extremes. This is a pattern of systemic and structural abuse, right? And so you need to have data for that. Research and data is expensive, and it is not a quick process, but we thought, let's start with what we have, which is our community of embrace mothers across the country, and let's put out a pretty rigorous survey. And so that's what we did. It was the Count My Birth survey, and we put it out at the end of 2023, and we had 500 women take the 30 minutes to complete it. And the data was not surprising, but deeply affirming, and effectively 1 in 2 women in that survey had reported obstetric violence, and they explained exactly what that looked like to them, how it made them feel, how it impacted them. And we were able to write a report, which was wonderful because it was the stepping stone for us to now say, okay, now we need nationally representative, proportionate data.
And that's what led you to Gauteng and KZN.
Absolutely. And so we were really, really fortunate that the DG Murray Trust gave us some funding to be able to make that research happen. And we did it in partnership with the Social Surveys Institute, who were just phenomenal. And this gave us a chance now to really test prevalence in 2 predominant provinces that have very high birth rates.
Is that why they were chosen? Why were Gauteng and KZN chosen?
A number of reasons. I mean, obviously, we would have loved to have done a nationally representative, full all 9 provinces, but research is very expensive, so we had to be strategic. We chose 2 provinces, 2 big provinces that, do have high birth rates. It was 2 of them in the Eastern Cape, and unfortunately, we had to make a decision, so we went with those 2. And also because they have both urban and peri-urban settings. And so we were able to have a look across different type of healthcare environments, what women were experiencing.
And you found that 60% of the women who were surveyed had at least one form of harm that they experienced during birth or post-birth.
Yeah. I remember taking the call from the researcher, the lead researcher in the office, and she said to me, Julie, I've pulled the data. Are you sitting down for it? And I knew it would be high because, again, our data said, 1 in 2 women, 50%, had experienced it. But ours, again, had not gone through the same rigorous protocol that this data was going to go through. And so I was expecting it to be less. I was thinking maybe 40%, which would not be good, 40%. But it was 60. 60% is it's an unacceptable number. That is 6 out of 10 women who have given birth in those provinces over the last 10 years, that was the duration of the sample, have experienced at least one form of obstetric violence. Many women had experienced multiple forms of obstetric violence. And when you look at what that actually looks like, if you look at some of the other realities of the women, so it came across patterns of vulnerability, multiple vulnerabilities. So you had women who were Black, young, unemployed, more likely to experience obstetric violence. It's a very sobering thought about how we treat women when they are at their most vulnerable, at a time when they should be receiving our most compassion and support. They are being violated.
Is there general awareness about what constitutes violations of autonomy, dignity, and consent?
So I'm going to speak about this in 2 parts. I think there's the awareness of the women themselves, and then there's our awareness in terms of what we've agreed as a country is acceptable or not. So let's talk about how women perceive this awareness. From our experience, women intuitively know when they've been treated poorly or when they've been violated, but they may not know that their human rights have been violated. And there's a distinction there. If you experience something that is in any way aggressive towards you or harmful, your body knows. You feel that discomfort. Sometimes it's extreme pain. In other terms, it's not being asked your consent or being ignored. You feel that in your body. And women are able to tell us that if they felt uncomfortable. But what is interesting is that they don't always know. They don't recognize that what they've experienced is a human rights violation. But then the legislation is in place to protect rights and dignity of healthcare users. We have the Constitution, which speaks to the right of bodily autonomy, non-discrimination, the right to access of healthcare, including sexual and reproductive healthcare, the right to live free from violence, and of course that you would understand to include gender-based violence, which is why we include obstetric violence there. And then we have the National Health Act, which talks about patient rights. We have a Sterilization Act, which speaks about informed consent when procedures like that are taken. And there's a Patients Charter, which talks about how patients should be treated. So I think there is an understanding that patients have the right, the people have the right to be protected, and women understand what feels good and what does not feel good to them. But there's a bit of a disconnect there about whom it applies to and when.
And why do you think there is this disconnect? As your understanding of the problem deepens, what is emerging about the social and structural root causes of obstetric violence?
If I may take one step back, I have had the privilege of meeting probably hundreds of healthcare workers in my line of work. And I've yet to meet someone who joined this profession because they have a desire to go on power trips and abuse women when they're pregnant. That's just not the case, right? I have met healthcare workers who are simply broken by the state of what they are needing to work in and what they know that they've had to be complicit to. And we understand that there's a term that is starting to gain a bit of understanding now called moral injury. And I think it's really important that we familiarize ourselves with that. And that is that healthcare workers may know that that the treatment that they give women violates their own moral compass, that there's a contradiction between what you deliver in a constitutional culture that doesn't promote respectful maternity care or within a constrained system and what you know to be right. And that causes an actual moral injury. Healthcare workers who know, I signed up to provide care. But in this environment, where I am one nurse where there should be 5 of us, I am working longer hours than I should be. I don't have the access. I know that this mother needs pain medication, but we have a stock out. I'm unable to provide it, and I've had to justify these things to myself in order to get through the day. This is causing actual moral injury to our healthcare workers. It is simply not fair. And so obstetric violence, whilst there is obviously, women are mothers, pregnant women, birthing women who experience it, they of course get the roughest deal. But this is a system where no one is winning. And so when we talk about what is emerging as the social and structural root causes of obstetric violence, we know it's a manifestation of something much bigger that's both structural and systemic. Our healthcare system has inherited the scars of colonialism and of apartheid, right? Which is why maternal health outcomes are still skewed along racial lines and why Black and brown women remain affected by multiple intersecting vulnerabilities, which include race and class and gender. And they're often the ones who experience the most egregious forms of obstetric violence, and our research shows this to be true. And I think it reveals deep inequalities in the healthcare system. We know that more than double the number of women who access public healthcare are affected than those who access private healthcare.
So you're saying that resource constraints at public hospitals are contributing to the prevalence of obstetric violence?
I'm not sure if you're familiar with this, but the World Health Organization has a model for intrapartum care for positive childbirth experiences. What is required in order to provide a birthing person with respectful maternity care, with the best level of care? And there are 9 components that the World Health Organization has decided makes up that. Most of these components require resourcing in order for them to function. So for example, access to pain relief strategies, okay? In order for that to happen, it requires medication to be readily available. And we know that we have a problem with stockouts here in this country where medicine is not available or not available at the quantities that are required. And so if you've had a cesarean section and you've been given 2 Panados, which I've heard firsthand from a mother that I met, how is that able to manage the symptoms of major abdominal surgery, which is what a cesarean section is? I've had 2. And so I know how reliant I was on the medication to be able to manage that. I don't believe, again, that the healthcare worker wanted to only be able to give 2 Panados, but if there's nothing else available, you're not able to provide adequate pain care. Another thing is continuity of care. Continuity of care requires adequate staff to patient ratio in order to provide that. And respectful maternity care is enabled by competent and motivated staff paired with essential physical resources. This is what the World Health Organization has said. And this model requires resourcing. It is an economic conversation that needs to happen if we're looking at how do we start to seriously reduce prevalence of obstetric violence. It requires the healthcare system to be adequately funded to provide this kind of care.
So respectful maternity care can't just be a regulation or an expectation that is required of health institutions. It needs to be well resourced.
I do want to add one point, which I think has got to be a fundamental that we've got to agree on, is that even in current resource-constrained environments, we mustn't lose sight of the fact that every woman is entitled to a minimum standard of rights-based care. And this must be our starting point when we engage in conversations around the need to shift the issue of obstetric violence, because otherwise, what can happen is that we can start excusing behavior. And the reality is that there is still a need for accountability with healthcare workers. You can have very minimal resources and still provide respectful maternity care. It is also possible. But of course, the entire system does need adequate resourcing in order for fundamental shifts to happen.
Let's talk about accountability now. What does this word mean to you, Julie, in the context of preventing obstetric violence and redressing harm?
Very good question. And I'm glad that you asked what it means to me, because I think what it means to people who have survived obstetric violence can differ, and I want to respect that. So I think accountability means that the healthcare system acknowledges, firstly, that obstetric violence exists and is a problem. And at Embrace, we've been really encouraged because we have had engagements this year with the National Department of Health, and it has been publicly acknowledged that there is a problem here. And that's an important first step. We need to acknowledge that we've not done right by the country's mothers, and that every single one of them deserves better. Then obstetric violence must be acknowledged as a form of gender-based violence. And I've said this already, but it must be included in strategic plans on gender-based violence and femicide. And this takes the issue beyond being a purely medical one and accurately frames it as a form of gendered violence that continues to devalue women and girls and mothers in our society. Because I think it's really important that we just remember that obstetric violence is a human rights issue and not only a medical one. And then again, accountability, as we've talked about it previously, financing a ring-fenced plan to institutionalize respectful maternity care is an absolute, it's one of the bedrocks of accountability, is putting in place what's required to make it happen. It cannot be left to individual healthcare facilities to build implementation plans. It must be directed from a national level. And adequately resourced by Treasury. And this will also require adequate and consistent monitoring by the Department of Planning, Monitoring and Evaluation that sits in the presidency, for example. You've got to put a plan in place. The plan's got to be financed, road-mapped, and then accountability has to be constantly monitored at a national level. And we need to ensure that we have a functioning complaints mechanism that women can safely lodge complaints, have them followed up, and have access to meaningful redress, which could look like medical redress, where women have been injured, often children have been injured in these sort of traumatic birth experiences. And then financial compensation. I know that's the awkward one we don't want to talk about, but often this kind of violence has lifelong impacts for that mother that has a financial implication. And I would say also always include mental health and trauma support. Mm-hmm. Always. That is what I think accountability sort of looks like for us.
South Africa, after sustained lobbying from various NGOs, including Embrace, the country recognized obstetric violence as a form of gender-based violence, but it's not recognized in law. So while it's important symbolically, it will only lead to accountability and change once it's embedded in law, policies, and protocol. That's the understanding, right? And we know this because other countries have led the way. In 2007, Venezuela became the first country in Latin America to develop legislation around obstetric violence. What significant developments have transpired internationally that can provide a guiding light for South Africa on how to ensure accountability in terms of legal and policy reform?
So there are a number of examples, and they're quite technical, but let me just run through things that, some examples that might be of interest to this audience. In Spain, for the first time, the UN's Committee on Elimination of Discrimination Against Women, which is referred to as CEDAW, condemned the Spanish state for neglecting to protect a woman from mistreatment, non-consensual procedures, and violations of bodily autonomy during labor. In 2024, an Australian study found that over 1 in 10 people had some form of obstetric violence when giving birth. In Kenya, the Court of Appeals affirms maternal health rights. A pregnant woman, again, a case of a pregnant woman who was denied quality maternal health care and who was physically and, I believe, verbally abused by hospital staff and was left to deliver a baby on a concrete floor, which is a story that we may be familiar with here. The Court of Appeals affirmed the High Court's 2018 decision holding the national and county governments to account for violating this person's right to health, dignity, and freedom from cruel and degrading, inhumane treatment, and they awarded her damages for harms and suffering. And then the African Commission on Human and People's Rights adopted what is called Resolution 625 in March of last year, 2025, and it marked the first continent-wide human rights resolution dedicated specifically to obstetric violence. And the resolution formally recognizes obstetric violence as a serious human rights issue and initiates the development of African guidelines to help countries prevent and eliminate it. So there are examples globally. Also want to just give reference to the Black maternal rights movement in the United States. They've done incredible work. I mean, if you go online and search obstetric violence in America, you will see the work that this movement has done to elevate the plight of Black women who are disproportionately affected by obstetric violence and maternal deaths in the United States. So there is definitely a global body of evidence building that is calling for accountability.
Julie, so then what should we be doing in South Africa to get the accountability that is needed here?
Embrace and the Obstetric Justice Coalition that we are a part of, we are trying to work on multiple fronts. In terms of legally, we were saying we need the legal recognition of obstetric violence in South Africa, and so this is to ensure that it isn't reduced to medical negligence or malpractice, which doesn't account for the full weight of the human rights violation that obstetric violence is. So that's the one thing. And we're calling for strengthening of reporting processes. So given the South African context, we have a number of institutions where reporting can happen. I think you mentioned them earlier, the Health Ombudsman being one. There's nursing bodies you can report to, the HPCSA and others. But we don't have anything that's dedicated for obstetric violence, which makes accountability difficult. And then another part of the legal argument is that we need to challenge prescription, which currently states that women have to report something like this within a 3-year period. And the reality is that that's not always possible for many reasons, including life, and that the realization of what has happened to a person may only happen long after they've experienced this trauma. And that doesn't mean that they don't deserve justice when they are ready and able to pursue it.
Julie, you've mentioned the Obstetric Justice Coalition. This is a grouping of organizations that are working towards ensuring accountability for pregnant women and postpartum mothers. Beyond the coalition, how can other NGOs help to build capacity within the health system or adjacent to the health system to provide the necessary support that pregnant women need or that postpartum mothers need as they're navigating having just given birth or being pregnant?
So I always feel a little bit uncomfortable with this question, and I was sort of sitting with what that discomfort was from. And I think it's because we're so aware of organizations that are already filling the gap. Some of them are established non-profit organizations. Others are churches, faith-based communities, community groups, doulas, trauma counselors, average community members who care about women when they're hearing these stories of violation. And in an ideal world, many of their services should not be needed. If respectful maternity care was implemented as per the guidelines that are in place, if it was funded for that to happen, so much of these sort of complementary services would be made redundant because women would be receiving full mental health support within at a facility level, or receiving the full complement of government services, and would be receiving what they need in order to have a baby and have that be a positive, caring, dignified and respectful experience. But that being said, there are ways that organizations are showing up for mothers, and we encourage that. There are organizations training doulas, and we know that having a doula, a birth companion, is an incredible way is a protective factor against obstetric violence, and providing additional training for more women to be qualified and figuring out ways to support that would be one way that organizations could be supportive. And then, of course, there is other kinds of accountability, whether it's education and training, you're really helping women to know their rights, to have antenatal classes be more available for mothers so they know what to expect in labor, and to really be able to understand that when they're not being treated well, that is something wrong, and then to know what to do about it is a wonderful thing. And of course, there's many various antenatal programs who could probably look at implementing a chapter on obstetric violence, really educating women, because going in with the knowledge before you give birth is also going to be protective. Not fully, but will be definitely helpful, and giving women, again, a bit of a pathway of what to do if this happens before, when you have that little inkling that something is not right, this is what you do. If you're listening to this and you've never heard of obstetric violence, is to first find out what that is, and to know that if you engage with women in any way and they are of reproductive age and they are likely to be pregnant, that this is an issue that can very likely affect them.
As we end this conversation, I just want to know, for NGOs that work with pregnant women and new mums, what can they do to raise awareness about what it means to give birth with dignity?
There's no shame in saying I've never heard of this phrase before. I'm almost certain everyone's heard of a story, but maybe haven't had the terminology for the fact that this is obstetric violence. So educate yourself. If you're an organization, reach out to us, reach out to Embrace. We have resources. We have a documentary series that we put together called Push Comes to Shove, which is available. You just need to apply to us, and it's a very short training process to give you access to these films to be able to use for kind of community conversation. And it comes with a guidebook. So you really unpacking the terminology, scenario playing. It gives you a resource to be able to have meaningful conversation with the people that you're working with, your constituencies. And then I would also say definitely follow us on social media. This is something that we are very passionate about. And so we will often provide resources, share stories, give information on what's happening in the country. And so, we want every opportunity that you have as a listener to speak about this. We ask you that you do it, because the more that we're able to keep the conversation on respectful maternity care in the public sphere, the harder it's going to be for those empowered to ignore it. And we ask you to speak about this often, and to start asking questions that allow women to share their birth experiences. It could start with, after your lunch, after listening to this podcast, going to your colleagues, going to the people that are around you who you know have given birth, and ask them about their experience, and be willing to listen without judgment. And then another thing that you can do is to help women report their experiences. That is currently quite a tricky thing to navigate, and it can be quite re-traumatizing to someone who's had a traumatic birth, and it's really helpful to have someone with you to help you figure out how to go through that process. Again, as I said, the more decision makers that see this as an issue that matters to people, the more likely they're going to do something about this. And so we really do all need to be calling for respectful maternity care for every person, no matter what.
Thank you, Julie, for this really insightful conversation about what it means to give birth with dignity.
Thank you so much for giving me the opportunity to speak to something that we're really passionate about.
And now over to you, those listening to this podcast. Using what you have heard today, you can try this reflective exercise. You'll need a pen and paper to write down these steps, or download the takeaway sheet from our website, dgmt.co.za, and go to the podcast section. Write down the following questions and spend some time reflecting on them by yourself, and then share your reflections with your colleagues or peers. Question number 1. What does giving birth with dignity look like to you? Question number 2. If you have a pregnant person in your life, how can you contribute to supporting a respectful birth experience? And question number 3. What can we do to ensure that all women in this country understand their birthing rights? This is DGMT's Learning Lunch. Until next time.